Hello, everybody. Thank you for coming. So this is our last seminar series for the semester. Rachel has asked me to remind you that they will start second semester on January 9th. So one of our goals of the seminar series has been to profile early career investigators as well. And so we are very happy to have Annie Duchesne, who joined us, joined the Department of Psychology just this past July. And she comes to UNBC from Montreal and Toronto, I hear. She kind of jumps.
I was really in between the two.
So I will let her begin her talk.
Okay, thank you. Thanks, Chelsea. So hi, everyone, and I guess hi, everyone online. So I first would like to, thanks, Rachel, who invited me to this series. And I would also just want to say one word. I've watched the past talks because I could not attend them, and I'm very honored actually to talk to this venue, and I think it's going to be a great opportunity to present a bit of my research, but also maybe where I want to go and how I want to connect with people within UNBC. And I think that from what I've been hearing in the past seminars, I think there's a lot of potential to connect our interests, hopefully. So what I'm going to be talking about today is the crucial role of context in understanding the interplay between ovarian hormones and psychological health in women. I haven't mastered the short title yet, so that's what you get. Okay, so let's start by having actually a definition. And I use the term context as it's a word that means something, but it's purposefully broad. And you will see that I use this term broadly on purpose. So just to go with a generic or general definition, the circumstances that form the setting for an event, statement, or idea, and in terms of which it can be fully understood. So if you think about context, and I'm sure every one of you have directly experienced or witnessed a situation, a statement, an observation where you're just like, whoa, I think that this has been completely misunderstood because there's a lack of contextual elements or contextual. And here you have an image of someone who basically wants to reach out because he's drowning, and someone just brings a soap thinking that they want to pat themselves. So when you think about this, and if you remind yourself of any experience along those lines, then it's easy or it's quite intuitive to think about how context is also important for any scientific inquiry. And I would say that actually identifying important contextual variables and trying to understand how they contribute to the phenomenon you want to study is actually probably in large part what scientific inquiry is about in this context, but I would say across disciplines. And with that, I would also add that then if you think about context as being very important to fully understand the phenomenon, multiplying the facets of context is probably a very good way in having a better understanding of the phenomenon you want to study. I'm not saying it's easy, but I think it's probably a good way to start or continue. So now let's go in the specificities of my topic, which has to do with women's psychological health and ovarian hormones. So I'm pretty sure everyone here, just looking at the distribution, have an idea of what ovarian hormones are, but usually, and wrongfully so, we associate ovarian hormones to estrogens and progesterone solely. And while they are definitely important and essential to reproduction, and they are also the main hormones studied in the context of behavioral neuroendocrinology or psychophysiology, they are not the only one. And there are other peptide hormones, but there are also testosterone is secreted by the ovaries, and it's an hormone that we usually forget and that we also usually overly associated to men, but women through their ovaries do secrete testosterone as well. So keeping with the context. So basically, just going back, and this talk will basically has to do with estrogen and progesterone. So I'm just going to talk a bit more about its distribution across lifespan. And here, what you see, it's just a graph of estradiol, so one main type of estrogens, and its distribution across the lifespan. And what I want you to focus on is just that you can see once you reach puberty, you have a significant rise in estradiol, and then it's going to pulse in a cyclical fashion, which corresponds to the menstrual cycle, and start to decay when you reach the perimenopause. And levels going to become quite low through the postmenopausal period. And here, the dashed line has to do with FSH level, and I don't want you to focus on that right now. Also, this really represents the cyclical or one typical estrogens profile of a woman, but a woman who would not have any children, because if a woman would be pregnant, you would then see kind of a widen and higher in amplitude peak in estradiol. I just want to say that progesterone levels, while not displayed here, have a similar, I would say, a pattern of secretion. So if we take one of those cycles, we zoom in, this is what we see on a typical menstrual cycle that goes along 28 days. That's again a very typical or textbook cycle. We understand the cycle in terms of ovarian hormone release in two main phases, the follicular phase, which corresponds to the first 14 days, and follicular phase in reference to the development of the follicle, which will then lead to the release of the egg. Hormonally speaking, the follicular phase is characterized by a rising in estrogens level. The first part, the early follicular phase, is usually the menses, so the menstruation phase, and the late part leads to ovulation, so the release of the egg. And then when an egg is released, you enter in another phase, the luteal phase, which is called luteal. Sorry if it's a lot of like, I'm kind of lecturing a class, but I just want to everyone being on the same page with respect to hormones. So progesterone is released from the corpus luteum, which refers to the luteal phase. And what you have in the luteal phase is basically fairly high level of estrogens and rising level and high level of progesterone, which will both decay, and then the cycle is going to start again, and menstruation is going to be initiated again. So what do we understand regarding the relation between women's affective disorders and ovarian hormones? So here I just brought like the biggest piece of evidence where ovarian hormones is somewhat related or associated with women affective disorders. So first, there are a series of symptoms and disorders that are specific to women and relate to their to certain or specific period where ovarian hormones are varying. So we have premenstrual syndrome, but also premenstrual dysphoric disorder, which is an actual clinical diagnosis, and that is characterized by a significantly more severe and actually depressive episode that happens cyclically at the premenstrual period. There's also postpartum depression. So these are affective symptoms or disorders that are manifested or locked in time with change in ovarian hormones. There's also important difference between men and women as to regards of stress-related disorders, where women are 2 to 3 times more prevalent in developing affective disorders such as PTSD and depression. I think this is a number that usually is quite known or people are familiar with. And then one last piece of evidence is that there seems to be a relation between ovarian hormones and stress and the neuroendocrine stress response. And why is that interesting or important? Well, the stress processes or change or dysregulation in the stress response is usually considered to be a major risk factor for affective disorders. And this is the element, I would say, that got me thinking when I started my PhD. And I was definitely interested in better understand how does ovarian hormones interact with the neuroendocrine stress response. And I was specifically also kind of wanted to understand better is the relation or are ovarian hormones making women more vulnerable to stress. And it's something that I was quite interested. So then just to give you, before jumping in, I just wanted to remind you the different stress systems. There's 2 main physiological stress systems, the autonomic response, which is associated with an activation of the sympathetic branch. And usually physiologically it's felt like this notion of the fight or flight. So your heart rate pumping, you're gonna have an increased blood pressure, you're gonna have an increase in sugar mobilization, energy resources, you're gonna change, you're gonna be way more alert and vigilant to what you need to pay attention to. And this system's kicking in really quickly. Well, there's a response that is delayed. Delayed, I mean few minutes after the onset of the stressor, and that's the neuroendocrine branch that's activated and leads to the ultimate release of cortisol from the adrenal cortex. And cortisol is responsible for, I would say, lasting effects. So again, really contributing to helping your metabolic, having energy resources. So it's going to work at the level of insulin. It's going to really help you synthesize new glucose. It's also going to help you try to moderate certain response that might be happening when you are in a threatening situation, such as controlling your immune response. It's also going to have a regulatory control on the autonomic nervous system itself. And I would say importantly, these two systems together have very important effects on the brain and will affect your behavior. The most known effect of stress on behavior is on learning and memory, and help you remember what you need to remember to not face this threat again or to face it better the second time around. So this is the summary of the stress systems. So now, oh, I'm so sorry. Like this is, I tried to different resolutions. I'm sorry, the resolution is pretty bad, but this is one of the first studies who actually looked at the effect of ovarian hormones through the different menstrual cycle phase and how the different menstrual cycle phase, as well as oral contraceptive user, might be react differently to a stressor. And what you can see here is that at the top, you have the cortisol response of men, and then followed by the cortisol response of women in the luteal phase, then follicular phase, then women on oral contraceptive. So basically what we can observe from here is that women are not showing a greater cortisol response compared to men in response to that stressor, but women who are in the luteal phase, which is the phase characterized by both high level of progesterone and estrogens, have an equivalent cortisol response to men, while women in the follicular and women on oral contraceptive have significantly lower levels. So clearly, it seems that ovarian hormones are actually interacting with the neuroendocrine stress system. But while this is really something I was interested in, and I don't know if something you would like to know, but there may be something else that has to do with the task per se. And I don't know if you have an idea how these people were stressed and how we got them to get this beautiful cortisol response. Well, we exposed them to a test that's called the 3A social stress test, TSST, which is the most commonly and widely used psychosocial stress paradigm, which consists of a very simple test. You don't know what's going on as a participant. You're about 5 minutes before the test arrives, you're coming into a room, you're told that you will have to perform a test, you have little time to prepare. When you enter the test, these are the person that are facing you. They are very evaluative. You're told that this basically will be an evaluation. You're filming, you're recorded. So lots like what's happening right now, basically. And I don't know where to get this. Huh? It's, yeah. So, yeah. And then the person has to perform an oral presentation for 5 minutes, followed by a mental calculation for 5 minutes. And this is the task that leads to the most consistent cortisol response across continents, across labs, so it is used as a gold standard. I'm not saying that there are not individual differences, but it leads to consistent cortisol response. So when I entered the lab of my former PhD supervisor, Jens Usner, they were very interested in understanding what are the different, because there's a lot of stuff happening or going on in this test, and what are the specific component of the test that actually could lead to a cortisol response. And they did a manipulation where they basically were putting the panelists behind a window mirror or directly facing the participant, like the usual version. And what they found, they basically found that only women when the panelists were put behind the window mirror, did show a reduction in cortisol response. So for men, whether they were in front or behind, it did not change their cortisol stress response. So when I came in, I was like, that's interesting. So it seems like maybe what we are seeing there is that women are particularly sensitive to social evaluation and direct presence of social evaluation. So maybe if I'm making a situation when there's an increased social evaluation, then I will actually have women to respond to have a greater cortisol response than men, and maybe this could maybe be a path by which women might be more vulnerable to the effect of stress. And knowing what I knew about ovarian hormones, I said, if this is true, then for sure it's going to be women in the luteal phase, because already if you expose them to traditional PSST, they show similar response to men. So if there was be one group or one subgroup of women who would show the highest cortisol response, it would be women in the luteal phase. So to increase social evaluation, I just surveyed the literature and basically came to this idea to say, well, whether you're a man or a woman, what seems to be anxiogenic is if you have to interact with someone from the opposite sex. So if you have to interact with women or if you have to interact with men. So we decided to just vary the gender composition of the panel. Usually you have always one man and one woman. So we put either 2 men or 2 women and tested the effect on the cortisol response. Oh, yes. So these are the response. So this is just so that you know, because I didn't put a lot of methodological information, and thank God, because yeah, I'm not talking very fast. So we have about 10 to 12 people per cell. So just so that you know. So what we see here is women in the luteal phase and women in the follicular phase, 2 different group of women. It's not a within, it's a between design. And what we have now is an absence of cortisol response when both women in each group are facing women panel. So not only we showed or observed a reduction, we actually could not induce a cortisol response with that context. But then what really was, interesting. What really was quite shocking for us is that when we were looking at the cortisol response in the men panel or the opposite sex panel, what we found is that there was only a strong, significant effect, and it was in the group of women in the follicular phase. And in group of men, we tend to see a similar pattern. So basically, men only responding to a women panel, so an opposite sex panel. However, I have to mention that we have a difference at baseline in cortisol level, and this, if ever you work with hormones or neuroendocrinology, if you have a higher baseline, your chance to actually have a response are reduced. So, and we tried to find out what this was coming from, and we could not explain any possible factor explaining this difference. Yes.
Did they know beforehand what the panel was like, or not? Maybe they didn't see anticipation.
No. So no, everyone. Well, actually, at that time, -10. It's before they were introduced to the panel. So everyone was introduced to the panel after this sample. Well, yeah, no, but it's a good question. Okay. So first, what this study demonstrated is that the effect of menstrual cycle phase on the cortisol stress response is context dependent. So by changing the panel composition, we now are seeing that women in the follicular phase show the highest cortisol response instead of being women in the luteal phase. So for us, this was quite novel, but we also showed that the gender panel composition is actually quite important to inducing a cortisol response at all. And then I don't know if you're curious about that, but there was also, they had also to report on their subjective or affective response to stress. And then, you know, I think that one would assume that the subjective response would go align with the cortisol response, but actually it was quite of a different story. While there were not a significant main effect of group, there was a trend for significant interaction of group by panel composition, whereas women exposed to men in the follicular phase tend to show the lowest report of subjective stress, so being the least stressed. Well, now we were, whoa, we were really kind of confused / interesting, but there's something you need to know about the relation between an affective or subjective stress response and cortisol is that they do not often match. And while we often think, oh, I was super stressed, I felt like I was stressed, so therefore my body and my hormones should be following that feeling, well, actually in the literature and in the experimental assessment of stress, that's rarely the case. And it remains kind of why is that? While usually those two responses co-occur, they do not correspond on one-on-one terms. So, yeah, sorry, we kind of, well. So what we did, we ran another study where we exposed women from the two different phases to a traditional TSST, and then we just look at the association between the cortisol response and their subjective stress response. And what we found is that basically we had a moderating effect of a menstrual cycle phase, whereas when you are in the follicular phase, the higher the cortisol, the lower the subjective stress response. However, when you are in the luteal phase, it's the opposite story. So the higher the cortisol, the higher the subjective stress. So these associations sometimes like, so basically depending on your hormonal milieu, the relation between your subjective stress and your cortisol response will change. So we had this findings, then we were like, okay, that's interesting. I think there's definitely something, but it's one study. So we did another study using a different stressor, a mat oriented stressor, but again, same thing. You think you're failing, but you're not, but we tell you you do, and then we give you negative evaluation. So that leads to an increase in cortisol response. We recruited women in the follicular and luteal phase. We were way more cautious on how to make sure they were in that exact phase. And we also use a different effective measure. We use a state measure of self-esteem, which is a validated tool to assess change in state self-esteem, which is exactly the domain we want to see changing as a social evaluative threat. And we found the exact same thing again. So we are confident that the moderating effect of menstrual cycle phase is actually something that seems to be happening. So just to wrap up, the effect of menstrual cycle phase on the cortisol stress response are context dependent. And we just show this by having a very small manipulation within a very widely used experimental task where very rarely the panel sex is disclosed. So that could be part of explaining some variation as well in the cortisol stress response. The menstrual cycle phase moderate the association between the cortisol and affective response. So again, if we think about the take-home message to say when you pay attention to context or when you start manipulating context, you may be exposed to another piece of the phenomenon you want to understand. And I think these two studies are quite revealing in that sense, because we were not suspecting at all that by making this manipulation, first we would see the cortisol response in the other phase than suspected, but that this big of a difference would allow us to also observe the strain in the dissociation between the affective and cortisol response, which then leads us to conduct other studies. And now, if we think about these two together, it's also open up to other questions. So then what it is that has to do with ovarian hormones that makes the cortisol response change, but not in that context, but in this one, what has to do with ovarian hormones that influence the association between the way you feel and your hormones. So we need to open our new sets of questions. And I think that for me, where I would like to follow is to look at the work that has been done, looking at menstrual cycle phase and actually cue or a craving response, because there's also interesting differences and moderating effect. And I think that one way I would like to approach these questions more broadly is to say, is there something when you are in the follicular phase that makes you more sensitive to cues And in that sense, by being more sensitive to cue, you might have a greater physiological response. But what are those cues? And why, when you have one man and one woman, you show a reduced stress response? Maybe because you're very sensitive to the cue of a woman, which is associated to reduced stress, and you're very sensitive to cues of men. When we lift out and we just put a cue of men, then being more sensitive, you would have a greater cortisol response. I don't know. That's something I would like to assess. But what we do know from the craving literature as well is that they observe the same moderating effect of menstrual cycle phase when they look at how cortisol is related to craving. So basically, when you are in the follicular phase and you have low cortisol, you have lots of craving. When you are in the luteal phase and you have low cortisol, you don't have much craving. And this has been observed in 2 studies, one cross-sectional, one longitudinal. So there's something there to be investigated. And I don't know if I will be the one doing it, but I think it's definitely worth understanding it. And finally, I just want to say one word about ovarian hormones and women's vulnerability to stress. So all the work that I've shown there thus far are definitely pointing to differences in how a woman processes the stress response, but does not mean that this makes them more vulnerable. And I think that that's a very important difference, and a difference I will try to emphasize more, because it's often a difference that is confounded or conflated, and I don't think it should. So just keep that in mind. Okay, so now I'm gonna switch gears, I'm sorry, and I'm gonna talk about menopause and cognition, and here again, the role of ovarian hormones. So just so that we understand, menopause is when basically our ovarian hormones or reproductive cycle is just going to a little rest, and which is associated with a reduction in the release of estrogens and progesterone. Just one word about testosterone. Actually, testosterone does not reduce or is not reduced as fast as estrogen and progesterone. Fun fact. So now what I want to say, I'm going to go like that. So what do we know about menopause and cognitive health? Well, there's been a lot of findings or a lot of research linking cognitive performance and ovarian hormones, and specifically estrogen. And there's been a lot of research in premenopausal women showing that higher level of estrogens usually corresponds to better cognitive performance, specifically on the verbal domain. While there are some also downside effects of estrogens that have been related with spatial memory and mental rotation, for instance. That being said, I'm saying that in quota because there's a lot of inconsistent findings with respect to these associations. But when it comes to understanding the role of ovarian hormones in cognitive health in menopausal women, I think that the piece of evidence that was the most conflicting is when we looked at the effect of hormonal therapy and how hormonal therapy helped or did not, or actually was detrimental to women's cognitive health. And what you are seeing here is an image that has been nicely put together by Rocca, which is one of the seminal authors who first showed that this discrepancy in how hormonal therapy might or might not help women, menopausal women, has to do with how do we understand and articulate what a menopause is, and shed way more light on the different facets of menopause. This is what I'm going to be talking about. So what you are seeing here, just as an image from Rocca, is basically here you have the odd ratios related to increased risk of dementia. And here you have, so this population, so which represents studies, of course, they are at higher risks of dementia because they were taking hormonal therapy and estrogens-based therapy, but late in postmenopausal. So late, we talk about over 10 to 15 years after being menopause, they started taking hormonal treatment. And then, so these are randomized controlled trials, and what they found is that the group of women who were in the hormonal therapy group had increased risk of dementia, and then they stopped the study for that respect. Then, however, you see you have actually way less risk if you take estrogens early postmenopausal, so few years after. So usually we talk about 5 to 10 years after your menopause. And then you also have reduced or low risks of dementia if you preserve your ovaries. So basically, if you add a menopause that was not surgically induced. So then there we have 3 important pieces of information related to what menopause is and what should we be attentive when we think and talk about menopause. And these are the years since the menopause, the age at menopause, oh, that's something I didn't mention, and the type of menopause. So, and basically the risks for dementias or the risk for cognitive impairment goes such as irrespective. So when you are not on hormonal treatment, the younger your age at menopause, the greater are the risks. And the same is true if you have a surgical menopause, so when your ovaries are removed, and that's why you undergo menopause. If this is happening, and especially if this is happening before 50 years old, you are also at greater risks of cognitive impairment and dementia. And when you think about it, there's a population that really, I would say, that needs a lot of information to better understand how the different type of menopause might be impacting our cognitive health. And this population is the BRCA mutation 1 and 2 carriers. And why is that? Well, if you are a BRCA carrier, you are at increased risk of breast and ovarian cancer. And these are the risks depicted here in percentage. And one way to alleviate those risks, and one way that is extremely efficient and powerful, is to undergo bilateral salpingo oophorectomy, so to undergo a surgical menopause. And this is actually recommended to be most efficient between 35 and 40 years of age. So you can understand from what I've just mentioned that if there's a population that needs to, a person that needs to make a decision on having a prophylactic surgery to help reduce their cancer risk, that we want to give them the best and most complete piece of information regarding what are the effect of BSO, this procedure, on the cognitive health and so cognitive and brain health. And this is a project that has been launched specifically focusing on women who are BRCA carriers. And this is where I did my postdoc at U of T. And this is a big study led by Gillian Einstein, which is exactly doing this. So looking at women who are BRCA carrier and trying to understand the longitudinal, the trajectory of cognitive and brain change as a result of BSO in that population. This is a study that runs now in Sweden, as well as in Toronto, as well as in Georgetown, because BRCA carrier, it's one, well, depending on certain population, but usually it's 1 out of 400 women. So and usually the women we are recruiting, they are middle-aged, so they have kids, they are fully active. So it's quite a very demanding process for them to come in and be tested. So recruitment is going, but it's going at quite a regular, slow pace. When I came in, there was also already the neuropsychological portion of the study that has been well started. And from those results, we could observe that women who have had a BSO compared to age and education match controlled showed a reduction in cognitive performance, specifically within the verbal domain. And there's been also another series of analyses that have been conducted showing that the years since, so your age so when do you get this surgery is also having an incidence on your cognitive performance, but only if you are carrying the ApoE4 allele, which is a gene risk factor for Alzheimer's disease. So you can see how this picture can be rapidly complex, but this is the result that I've been coming out from this study. So I came in to look at the brain of the woman in this study, and I was specifically interested in one region, which is the hippocampus. Why? Well, the hippocampus is a very the region that has a lot of estrogen receptors, that really is responsive to estrogen. Deficits in verbal memory has been associated with change in the hippocampal volume, so the volume of this region. And also we know that atrophy within the medial temporal lobe, the hippocampus specifically, is one of the earliest change we observe in people who will undergo Alzheimer's disease. So we were definitely interested to look into the structure and the integrity of this structure with respect to the population, the BSO population. So this is what I have to present to you. And these are individuals, so very, very, very preliminary. And what we see now, what we are seeing actually, so you have the 5 BSO, 5 controls. You see their age range, their education, and you see that basically the age at BSO in that group range from 35 to 49 years old. And what we see now is this is on verbal recall, and this is on hippocampal volume, so the volume of the hippocampus, and there's no difference. But you see that some dots are in black, black around, and these are usually in the higher quartiles, and these are women who had a BSO but were on hormonal therapy. And again, while at this moment we can only qualitatively discuss those quantitative results, yes, there's no other way to say this. I think that what is interesting is that, yes, women who are under hormonal therapy and have had a BSO seems to be the one who are driving the group up in both the verbal recall and the hippocampal volume. And if we look at an association between the two, there's a significant association between verbal recall and hippocampal volume. So again, this is very preliminary. I think I have also, yes. So then this is another set of results, more people, but a bit more conflicting problems. I just want to point to you that there's a significant difference in age and in education years. So the difference you see here, you see that women with BSO have lower level of estrogens, which is expected. And these two are individuals which are on hormonal therapy. But we also see here a significant difference in hippocampal volume. But I want to put that in bracket because, again, at this point, the groups are not fully matched on education and age. And that might be a reason why we see that difference. And this is the Swedish cohort. So we have, and what we are working now, what the lab is working is to try to have actually questions that are distinct among sites, but also always have the similar assessment so that we can pool the data together at one point. So what we are seeing here is very preliminary, and I'm very cautious not going further because we need more people, but there might be alteration to the hippocampal integrity, and it's something that really needs to be further investigated. So just again to summarize this, so so the relation between ovarian hormones, menopause, and cognitive health is context dependent, definitely. And this is not my work has not directly shown this, but the work by Rocca has clearly established that years since the type of menopause and the age at menopause are crucial factors when understanding menopause and cognitive health. What we see is that BRCA carrier with menopause have a difference in certain cognitive tasks, and I think it's too early now to really talk about cognitive health. There could be differences that, again, are not suggesting that they will undergo significant cognitive impairment, but I think it's important to report those. And then one last kind of, again, another doing this research and thinking about menopause context, and it's important for cognition, we were reviewing the literature and we were just like, well, I'm looking at other recent research, looking at cognition and menopause, and I don't see menopausal type. Usually when they go, they will say menopausal women at least 1 year since their last menses, which obscure us completely to were they women with oophorectomy and what age were those women. So it was a sufficient concern that we decided to actually systematically review the literature on cognition and menopause from the year 2016 and try to look how many of those papers actually distinct the different type of menopause, especially within a field of cognition, which we know that menopausal context is having an effect. And now we are kind of finalizing the analysis, but what we see is that out of 51 papers, 41% are actually not distinguishing any menopausal variation at all. So not only we don't have demographic information, but just the way that they refer to menopause is like a one thing, a one concept. And yeah, so I feel like this is also going to be an interesting aspect to think in the future, is like how to systematize the idea that menopause is not a one thing, but it's a thing that has multiple layer and context. And if you're not attentive to that, you're missing out on the relation between ovarian hormones and cognition. Okay, so if I have like just maybe 5-10 minutes, yeah, I have. Okay, so I just want to talk about where so this is what I've been doing at my postdoc and my PhD, and now what I'm doing now. So I try to keep this idea of context, but complexify what context means, and complexify what context means to women. And this has been, there's some, I would say, event in my life that helped me thinking about that. And one of those events were when I attended this amazing conference, Neurogendering Conference, which was a conference that resembles scholars in philosophy, anthropology of science, sociology of science, and neuroscientists together. And the idea was, how can we think about women's health and women's brain and neuroscience, but being more integral to what it means to be a woman socially speaking, what it means to be, is there a different layer of oppression that are not accounted when we study women and we study their brain? Are we making shortcuts when we look at the association between hormones and a behavior? Are we overly thinking that women's emotions are just the result of their hormones and biology? So all these different perspectives that sometimes you read a paper and just like, that feels just wrong. But you have a hard time pinpointing what is wrong because the study is done, everything seems good, but there's these layers and nuance within, I feel, within the field and also within the way questions are addressed. So I joined in, and I think for me, I was like really interested to learn about all those different perspectives. And I think the thing that stuck with me, the thing that I wanted to share with them is this idea of women being vulnerable or inherently vulnerable to the effect of stress. And this could just not sit well with me. And I think that when we hear that in the literature, often people forget that women are also going to different paths of life. Their social position is different. The way they will experience stress, the type of stress, and how this might load in and how this might actually influence the relation between hormones and behavior is really underscored, or you don't talk about it because it is tough to think about this, but I think it's still quite important. So I had a conversation around that with two colleagues, Robin Bloom, a philosopher from Michigan State University, and Noor Zainab, which is a behavioral neuroscientist and studies the fear system in mice. And we just came out together and we had this conversation about, so because I don't know if you don't know, but I'm gonna tell you something. Now there's a huge momentum or movement in having female animals included in any research you're doing. And I think that the reasons for that are very valid and important, but I think there's a lot of scholars who are also concerned about some of the possible downside that has to do with adding female, but maybe holding to quite old questions on how to assess the problem of sex difference. So we came together and we just had this conversation about PTSD and basically saying, so our female rodents help us understanding why women have more PTSD. And then we're just like, well, let's think about that. So we start actually having a conversation together and thinking about what does it mean to have female in an animal settings, and how actually there is a problem when you only use males, but there's also a problem if you consider that female mice is a better model for women disorders than men. So there are these different layers of discussion that we start articulating together. And that led to a publication, like a conversation paper that is now under review. So, but I feel like this kind of exercise, while it doesn't lead directly to research, to a questions, it just opened a new realm of conversation and trying to help us think about how can we maybe have a research, and even a research at the animal level that is more cognizant to the broader context of women's health. And like an idea such as, for instance, if social hierarchy is very important to, let's say, women PTSD, maybe studying social hierarchy and how does this affect stress could be an interesting avenue in animals. So just trying to think a bit, not outside the box, but just generate other boxes. And that was something that I really, really appreciated. Then there's another projects I'm working on, and again, it's very conversational. I talk a lot, and I think that's how my brain works. So it has to do with chronic stress in women. And again, with this idea that women are vulnerable or more vulnerable to the effect of stress, this is a conversation I had with Aria, who's completing her PhD and looks at emotional labor and stress. And emotional labor is basically when you're doing a job and the main function of your job is to be emotionally available, or it's to modify your emotion for the needs of the organization. And this has been first studied in customer services or in airplane, flight attendants, sorry. Yeah, so, but then it has been extended to the healthcare system, and we know that there's ways of doing emotional labor. There's different types. You can do deep acting, fake acting, and we know that these are related to different health outcomes, and they are particularly affecting women. And so talking about this conversation, Harriet is doing an amazing work looking at 911, people who receive call, and how gender and emotional labor has to do with that project. And then we were talking, like, there's some aspects of women's stress that I think are just completely obscured when we think about the difference between men and women. And we kind of nailed three main themes, and I think we would like to articulate something and maybe develop a chronic stress tool around that. And one has to do with physical appearance and how how basically seeing yourself and how the presence of your body and how feeling your body, how the way the clothes you wear, how the fact that they are tight on your body or not, how this influences the perception of yourself and the awareness of your physical self outside of your bedroom. And how this on a chronic, if you think about daily and yearly, might actually load to this idea of chronic stress. The second is the sense of safety. And again, going from this idea to when you walk, everyone walks, everyone runs, everyone does, but if you're doing it with the idea that you might be, you're all tied to your keychain, or you're just always thinking, there's this constant state of vigilance that women often have or are learned to or develop. These are also, I feel, while they are not specific events in your life, they might load on your stress systems and on your way to apprehend stressor. And then finally, the notion of emotional labor. If your job demands you to be emotionally available and producing emotion that you're not in agreement with, maybe this is also on a chronic level quite detrimental for your stress perceptions. So this is something that I'm currently doing. And then there's some specific aspects that I'm interested in. I'm working with a student here at UNBC, and has to do first with girls' experience, the puberty transition, stress and psychological health. Again, taking more of a social and gender perspective on puberty. And here we're with Brittany, she's looking or interested to look at how pubertal timing and delinquent behavior are related, because they are. But instead of looking at this, saying, look, what are the factors in early pubertal timing that might be related to this link? And she's taking, social take, so peer, the type of peer, the age of your peer, the kind of behavior you do, does that differ? So that's what she's doing. And another project, postpartum depression and stigma. So I talked about postpartum depression before as a normal phenomenon, but postpartum depression, or just postpartum per se, is also a highly sociocultural phenomenon. And there's a lot of stigma that is concentrated on women when she experiences depression following the birth. So stigma related to mental health, stigma related to mothering, stigma related to possibly taking treatment while having a children and the consequence that this has. And Maddie, who's an undergraduate, she's really interested in understanding how those stigma or those beliefs might be shared or not embodied, but actually might be shared by healthcare students, and what could be the impact of that. So I think I'm so sorry, I keep talking. So I just want to say few things, because there are challenges. So as you may see, my more recent research is getting a bit away of hormones, and it's not that I'm not interested in the role of hormones anymore. I just feel I need to refresh my sets of questions and perspective. And I think that sometimes doing that might ask you to take a side tangent, write a theoretical paper, and come back and have different questions. And I think this is the path I want to take for now. But I'm also always interested in better understanding hormones and their role in behavior. So looking to this, being attentive to context, I think as one core challenge is there's a lot of, it's infinite basically. And you know, everything I present to you, my results were done on like a very homogeneous bunch of undergrad between 18 and 25 years old. Same thing for the women. I've never talked about how having a BRCA position might intersect with their ethnicity, if they are immigrant or not. There's tons of other variables that were not addressed here. But I think that it's like exercising, it's really like exercising a muscle. When you think about context, you think about context more, and you think about what your study brings and what your study do not bring. And I think that those two questions are as important one another. There are conceptual and methodological tensions. So I'm doing quantitative research, and sometimes my ideas hardly fit the toolbox that I have. So I think that then I'm facing to, okay, what do I do? Do I just go somewhere, or do I take another take? Like, and sometimes I don't know. And sometimes I will decide to take a quantitative side or experimental side, but being very aware or telling that this is not the full picture and there's some piece missing. It's a longer and unpredictable process, and it's a humbling journey. And while I'm saying this, yes, because whenever you take on new discipline, you're always a newbie. You don't know, you make mistakes, you just gonna use the bad words, but I think it's perfect, it's fine, and I think it's essential, because remaining humble when you do research is probably the most important part of all. And I would say if it's something that wherever spoke to you and you're just like, I would like to do this, but it's so overwhelming and I don't know, I would just say situate your research. And that's what I try to do. Sometimes what I've done, the data I've collected, I could not assess all those variables I would like, but I know them, so I will talk about them in my paper, and I will say they're important and they need to be addressed. So I guess that if one situates his research properly, then everyone is moving forward. So I would like to thank, there's so many people I would like to thank from Montreal, Toronto, and now Prince George. And there is some people here, but there's way more people that have discussed and chat and had coffee, and yes. So thank you, everyone. Questions? Yes?
Have you looked at how PCOS can affect regulation? Because some of the symptoms for PCOS is anxiety and depression, but I'm not sure how one affects the other.
Yeah, that's a very good question. I don't know if you say polycystic ovarian. So does everyone know PCOS? So polycystic ovarian syndrome or symptoms or syndrome, but is basically, well, and you will experience a menopause quite early out of this, and it's a very complex. It's complex. It has a lot of variation in hormones, and there's in Toronto, there's a group who would like to look at PCOS population. And I think that it's always having access to it and how to understand, again, in a quantitative world, what could be a good control population. But yes, there's a lot of variation. The thing that in PCOS population is that their variation in hormones are a bit different and maybe less standardized, I would say, as of course going from a nephrectomy. I don't know if it answers your question.
I have a question about, so just in terms of the stress test and when the difference between the way the opposite gender or the same gender, I'm wondering, is the theorizing under that reason for the increased stress, is it related to sexual tension or sexual attraction? And if so, does it vary based on people going through it? Or is it more based on fear, the idea of fear and of not understanding the other gender?
Well, I can speak briefly to so for that study, everyone was heterosexual, and they rate the attractiveness of the panelists. Well, now I'm thinking about that, I was like, okay, I don't know how honest they were when reading. Well, some were too honest, I would say, and, but we try to factor that in also, and to try to think. And from the results we acquired, we did not see any association. So I was more into an unconfirmed fear, if you were to ask me. However, I don't think we assess the aspect of attractiveness, but attractiveness leads to discomfort and leads to fear because there's maybe more to lose if for whatever reason you value the person in front of you. So there's probably a kind of a complex interaction with respect to that. But that's a good question.
I mean, you mentioned the social cultural context of the postpartum stigma depression. I think all this research has to be looked at from a much broader perspective. I mean, you mentioned that at the edge.
Yeah.
I mean, that's why you look into the biological comparisons.
Yes.
But you have to, well, it's a cultural, social culture, that's the main thing. And I think it's going in psychology much deeper. Also, the subject of shame. It's a subject I'm personally working on at the moment, and women. And I think it needs to be looked at much deeper in historical context.
Right.
And I think that's very crucial. And also in religious context. And comparing different traditions, which is difficult now in our, where everything is connected. You don't have the anthropological separate views anymore, where you have really separate matriarchal or compared to our patriarchal system, where you can look at the differences, because I think this is one of the most crucial parts. Also to look at language, how that, I looked a little bit on that in regards to shame. Shame is one of the crucial elements, I think, in the whole thing, which has been much overlooked in psychology, which is much deeper in many, psychology is stuck in many regards nowadays.
I really like how you talk. I don't know if this is a conversation.
It's true, but it's stuck in regards of we deal with depression, we cannot treat it. We have all these suicide cases, we cannot deal with it. What we do is in psychiatry, we medicate it. And I think there's other things we have to look at. And I believe personally, by looking into this very deeply, shame is one of the crucial elements. It's connected with religion, with many things, and the female part is at the bottom of it. If you look at the language, in European languages, I'm German from my background, shame has the female, it's a genital female area, and also shame, it's connected with it very deeply. And I think this is actually my opinion at the root of
no, and I feel like that's also, and when I speak about the misnomers and how we name things, and we see that a lot in psychological, in history of psychiatry and women's, and everyone knows about the hysteria and where hysteria stems from. This is kind of an example, but I cannot be more in agreement with what you're saying. And I think that when not the fracture, but when the for me, I still want to assess women's biology, and I want to have that too. How do I do this? So how, and I think that it will be for a while to oscillate between having to delve into heavily theoretical and historical perspective, and then coming with questions that might be, but I think the way questions are asked have to be changed and reformed, but we also have to think that there is a huge biomedical systems who are functioning, and I had this question, should we retract basically and just reorient the way of research, or just try to communicate that its importance and do it from not a place of pointing finger, because everyone wants, I think at the end of the day, everyone wants the best for the population they are studying, and they think it's the best, and maybe having a conversation. And for me, I know I talk a lot, but it seems like it's working. So I try to enter in conversation with a lot of people and see how.
And I think that is the approach, to work interdisciplinary,
yeah,
which we have to do,
yeah,
because otherwise we can't solve this.
Yeah, I agree.
I just want to see if anybody on the line would like an opportunity to ask a question.
I completely forgot about that.
Okay, well, I just wanted to really thank Annie for presenting today, and that we will be rejoining back on January 9th. We have Chris Busey, Health Sciences Postdoctoral Fellow, presenting with us, and I'll release the schedule as soon as it's confirmed so everybody knows what's coming up in the winter semester. So thank you, Annie, for sharing about your work today, and I encourage anybody to stay. We have the room till 2:30 if you want to discuss with Annie further. Okay, thank you.
Thank you.